Good evening, everybody, and thank you all for joining us. My name is Celeste, and I am the Patient Safety Officer here at the hospital. And I want to welcome each of you to our discussion this evening. We have 30 minutes allotted for this discussion, so we'll try and be respectful of that. I want to welcome Todd. For those of you who don't know Todd, he's a unit manager in the emergency department. Teresa, welcome. She is our quality manager for the organization. And Jordan, thank you also for joining us as the informatics manager, in which the ED falls under your division. So we are here today to basically discuss a never event that had occurred, and we'll be getting into the specifics of that particular event. But I just want to remind each of you what a never event means. In Leading and Managing in Nursing in 2000, a book published in 2014, author Victoria Falsley defines a never event as errors in medical care that are clearly identifiable, preventable, and serious in their consequences for patients. And that certainly is what we have in this particular case. And then I also want to let you know about patient safety, because after all, that's really what we're here talking about, is how to improve our patient safety. And the Agency for Healthcare Research and Quality, or AHRQ, defines patient safety as the avoidance and prevention of patient injuries or adverse events resulting from the processes of healthcare delivery. And we certainly are going to talk about our processes and some of the things that we think could have happened in this particular incident. So let's dive right in here. This never event revolves around a 58-year-old Hispanic construction worker who came into the ER basically with some vague gastrointestinal symptoms. He was assessed by the triage nurse, sat in the ED waiting room for his turn, and subsequently died in the waiting room. So his background, a little background on the situation itself. He presented to our level 1 emergency department, which is a 70-bed unit, by himself for complaints of abdominal pain, which he rated 3 on the 1 to 10 pain scale. Stated he felt funny over his left flank and aching pain to his left buttock area. The patient was triaged by an RN with blood pressure charted in a sitting position of 181/86, a heart rate of 98, oral temp 99.2. Patient's 5'7", 278 pounds. Skin was moist to touch. He denied any nausea, vomiting, blood in the urine, difficulty or frequency in voiding. And once he completed that triage, and this information was charted by the nurse, she had him wait in the waiting room. His background, through his very sparse medical history records that we had on file here at the hospital, as well as through interviewing his wife. The last time this patient saw a physician was about 19 years ago, and at that time he was diagnosed with hypertension and pre-diabetes. The physician recommended medication management and twice-yearly follow-ups to monitor those two diagnoses. He also recommended some weight loss at that time. Metoprolol, 25 milligrams once daily, was prescribed. However, the MD reports and the notes report that the patient did not return to visit the physician, made no lab appointments, were no shows for those appointments. The patient's wife, he and his wife had been married 29 years, states that he didn't like doctors or hospitals, and so therefore he didn't go back. He also states that the medication made him feel bad, so he didn't take it. So basically there was only a 2-week history of the medication. Social history includes 1 pack per day smoking for 30 years, a case of beer consumption every weekend per 30 years, and his wife states, wife states that he's had low back pain and abdominal pain diffuse, not really anything specific for about a week. Did increase in intensity, but he sought no medical treatment until he came to the emergency department at that time, and his wife was not aware that he was coming to the ED. So that's about all we know of Mr. Juarez. So right now I'd like to ask Todd, the unit manager from the emergency department, to talk to us a little bit more about their triage system.
Thank you, Celeste. You know, this is a tough situation, but first of all, I'd like to point out that after an initial investigation, I determined that the patient was mistriaged, in that he was made a level 3 instead of a level 2. We use a triage procedure called ESI, which stands for Emergency Service Index. It's a 5-tier system where patients are triaged as from a level 1 to a level 5. Level 1 requiring immediate attention to prevent loss of limb or life, i.e. resuscitation, through level 5, which is non-urgent, such as dental pain, coughs, and colds. The ESI is a guideline to determine acuity level and to determine whom the provider sees first. This particular patient, Mr. Juarez, presented with abdominal pain, and his blood pressure was 181 over 86, which you stated, Celeste, which would have made him, by our ESI level, a level 2 by our algorithm. The triage nurse that triaged him determined that he was a level 3 and placed him back into the lobby. Whereas if he was a level 2, he would have been taken to the back immediately and be seen by a physician or provider. I want to point out that Mr. Juarez, as Celeste stated, was high risk due to several factors, such as a history of smoking and alcohol use. He was a diabetic history, his ethnicity, and his lack of medical care. Now that's just to name a few. There was other things with his obesity and things of that nature. But any number of these, any one of them, with the combination of the chief complaint that he presented with, abdominal pain, would have moved him into that level 2 category and brought him back immediately to the back instead of putting him back out in the lobby. Our policy states that if, obviously, level 1s, they're resuscitated, they're in resuscitation, they're in immediate danger, they're always taken care of first. Level 2s are always brought straight back. Abdominal pain with history, with presenting symptoms like Mr. Juarez, chest pains, things of that nature are brought straight back and bypass triage. But in this case, no beds were available, and he was triaged at a level 3 and then put back into the lobby. Even if there's no beds available, at a level 2, he would have been the first to go back. Or, at the very minimum, there would have been a call from the triage nurse to the charge nurse. And in this instance, there was no call made. In my initial investigation, I read an article by Ruth Sorrell in Emergency Medicine News in August 2011, and in an issue titled, "Is Triage Really Necessary?" She stated that EDs need to use systems and space more efficiently. And at this time, I'd like to propose a question to this committee. Can we utilize a physician in triage to conduct a quick assessment on any patient that presents with an ESI level of 2 or 3? Or at the very least, provide the physicians on duty with a walkie-talkie, a phone, or any other communicative device in which the triage nurse can contact them on any level 2 or 3 that has to wait until a bed opens up. So after my initial investigation and with this explanation of the ESI, I'd like to propose that question to this committee.
I appreciate that, Todd. I do want to remind the committee members that we practice no blame here at this organization, and so whether or not the nurse made an error or what have you, we all know from having these type of conversations before, it generally is a process problem and not a person problem. So
Absolutely.
we just want to keep that in mind, that the nurse here is not to blame. We've got, sounds like just from just a general investigation we've done, we got a lot of issues going on. So just want you all to keep that in mind as we move forward in our discussion. Teresa, as quality manager, would you like to address for this committee kind of where this NEVR event falls, and what your role and helping us to move forward is going to be?
Yes, Celeste, thank you. Thanks for reminding us about to not blame and work towards a solution. I'm going to be referencing some good information that I found in regard to NEVR events and how to prevent them, and what the work that this group needs to do for the future, now and in the future. It was in the textbook Leading and Managing Nursing. The author is Victoria Falsey, and it's 2014. The chapter is Managing Quality and Risk. In a NEVR event, the Joint Commission Regulatory Organization requires voluntary reporting. Another fact is nurses and other multidisciplinary staff members can play a pivotal role in prevention by adhering to best practice standards and ensuring quality standards for high risk, high volume practices that can reduce adverse events. In an effort to proactively identify and reduce future risks for patient safety through the completion of a failure mode and effects analysis. I'm sure y'all are aware of it. It's abbreviated FMEA, and this is actually where we will work with this multidisciplinary team that'll participate. I'm recommending that we do a root cause analysis. We will be using a very popular tool now in quality. It's the fishbone tool, and I'm sure that some of you all are familiar with this. But it's going to help us identify how and why this terrible event happened, and it'll help us work towards finding a solution. The root cause analysis will lead us to the development of specific risk reduction strategies, and in certain situations, this plan will actually need to be reported to the Joint Commission as well. Also, I would like to ask the question about utilizing, or making the suggestion about utilizing our hospital decision support team here at DRHA that will help us with data retrieval, so we can see where we're actually at and do some random auditing. And the question is, how many charts do we want to review? Let's look into the past, I think, some, and then set this up. It's going to be important that we find a way to measure where we're at and what percentage of patients are we actually addressing out of range vital signs, as in this situation, Todd, that you suggested. Another question, I think, is, are nurses overriding hard stops when it comes to a red alert on those? As far as recommending, we've got to start measuring where we are and what our goals are going to be for the future. Todd, you provided us with some information earlier in the week just about triggers, and that was some great information, and I appreciate that. Some evidence-based information that another facility was using to help them solve their problem. Thank you for giving us that as a group. But what I would like to suggest that we should establish baseline measurements of data. We can retrieve those monthly. We can aggregate those into a quarterly report that decision support can automate for us, and we can see it in real time where we're at on our percentages. We can analyze and interpret this data in an attempt to reduce the percentages of patients that don't have those out-of-range vital signs addressed. And then we can come to some conclusions about how we want to improve quality. That's about all I have right now, and I think I've thrown some recommendations out there to you all about
Teresa,
measuring and.
Can I ask some clarification? You had posed a couple of questions for us.
Okay. Okay.
And basically, I'm going to try to sum that up. So basically, what you're asking us to measure by the data retrieval and doing the chart audits and such, are you number one? You're asking the current system that we have in place, is it really working? I mean, is the information and data we're getting, is it working? Are we using the data? Not only are we gathering and entering it properly, but are we following what the system
Are
is
we
telling us
taking
to do?
an appropriate action
Okay,
that a
okay,
process has been defined, which
okay,
the ESI is already in place there. This is what we need to see, why it's not working. I'm sure we're going to come up with some, it could be related to staffing, it could be related to
right.
training, precepting. There's a lot of things that I think we'll find out once we find out how good or how bad we are with our percentages.
And I also liked you asking the question, are nurses overriding the hard stops? And I think that's going to be an informatics, that's definitely an informatics question there. Jordan, again, Jordan, you're the informatics manager, and you're the man with the plan for this computer system. And so if you maybe could give us some insight into you know, some of the informatics that played a role in this, or what we're going to do, and help educate us on that, that would be great.
Absolutely. Thank you, Celeste. I think it's really appropriate that we've kind of talked about, Todd kind of talked about the present situation, and the current, what we currently use to triage our patients in the ER. And then Teresa mentioned going back into the past to find out how often and when this is happening through chart audits and stuff like that. And I would actually like to chat a little bit about the future. After some discussions with some of the nursing staff in the ER, we've discovered that our EHR is not, the hard stops are there, but they aren't as blatant as maybe they need to be. So when I did some research, I came across two articles, because the other thing the nurses talked about is moments of overcrowding where the ER is full of people, and you know, maybe numbers didn't report out enough for there to be appropriate staff at that point. You know, that always happens. We go off these matrices, and then, you know, 20 people come in the ER that we would have never planned for to begin with. So I came up with a couple articles. First, let me say this event is a terrible thing. The term never event is really appropriate because we don't ever want these to happen. So I came up with these two articles. The first one is by Rooney and Schilling. It was written in 2014, and it's titled Point of Care Testing in the Overcrowded Emergency Department. Can it make a difference? And the second article is by Weston and Roberts, written in 2013, titled The Influence of Quality Improvement Efforts on Patient Outcomes and Nursing Work, a Perspective from Chief Nursing Officers at 3 Large Health Systems. These two articles really helped develop the framework for my ideas. The first idea is the overcrowding in the ED. According to Rooney and Schilling, point-of-care testing, when integrated into the electronic medical record, can lower the instances of overcrowding by quickly offering diagnostic information on patients, allowing caregivers to appropriately treat and move on to the next patient. We know point-of-care testing is actually bedside testing. To put it in the best frame of reference, I would say think of finger sticks. Like when you do a finger stick blood sugar, it's considered a point-of-care glucose because you get immediate results. Sometimes you know results before they even get planted into the EHR. So by doing point-of-care like blood gases and point-of-care hemoglobins and things like that, we can discover, you know, the patient that we might be, our data might be telling us from vital signs and things like that is having a bleed somewhere, and then their hemoglobin is 9.0 at the bedside. we can maybe maneuver them around when we have somebody who's reporting out as a level 2 with the data that they're getting from the EHR. We can switch out and make maneuvers where we need to make them, so the overcrowding becomes less of a problem. We process people faster and more efficiently, so we can get them out of the ER, so other patients that need a little bit more direct care can be taken care of. And the second thing is that Western and Roberts discussed using data to support clinical decision making. If the electronic health record template had red flagged the client's elevated BP, their diaphoresis, their funny feeling or sense of impending doom, because we all know that that's a thing, and it exists, and then opened new areas of the template that also pulled information from his past history, like Todd was saying, that made him at higher risk for what happened to him, it may be, and then, like Teresa said, hard stopped the nurse, literally brought up a notification that they absolutely have to document what they did, that a physician was called, or that a charge nurse was called, and that you have to document it. That way we know that it's happening, because when it's not documented, we don't know. So this hard stop, by using current information from the client, pulling information from the history of the client, would stop the nurse and say, this patient hasn't been seen by a physician in 19 years and has a pre-existing history. How long has this been sitting and festering and becoming a problem? And then maybe it would have had them recheck blood pressure, or maybe the hard stop would have just urged them to call the charge nurse and get her or his opinion, or call the physician. I actually really like Todd's idea of having a physician who's set aside specifically to help reassess these middle-of-the-line patients, because at first, without the patient's history, he could be leaning towards a level 3. I know his blood pressure says level 2, but he could be leaning towards a level 3 because his abdominal pain isn't severe enough. But then his history makes him lean back towards the level 2. So by having a physician come in and assess this patient, we would have known definitively that he was the level 2 and needed to be processed much sooner than, the guy who stubbed his toe. So those are the ideas that I came up with. And the question I'm asking is, should we integrate point of care testing, or should we integrate hard stops, or should we go ahead and have the ideas work within one another to move forward?
I would just like to add just something. I think that each of us have come up with some really good strategies for change for this situation. And I think we can make a big influence system-wide once we work to solve this problem, so this doesn't happen again. So.
Never events are never fun. Certainly not for us trying to figure out what happened, and certainly devastating to the family who came to us for help. Patient safety is at the forefront of everything that we do. That's why we're here. The patient died. Was it preventable? Maybe not. We'll never know that for sure. But what we can do is look at this situation from our standpoint as a learning, and say, what happened? What can we do to potentially avoid this again? And can we put some processes in place to hopefully never allow this to happen again? We had some very good, everyone had some very good questions. Todd, your question about triaging with the physicians, either in person, walkie-talkie, just a physician that was devoted, especially in a 70-bed ER at a level 1. Perhaps we do need another physician, or perhaps a mid-level provider like a PA or a nurse practitioner might be an alternative. So I liked that question a lot. Utilizing hospital decision support and data retrieval to pull in old records to help with that clinical decision making, to allow that nurse and the system itself to help guide that. Hard stops that are not overridable, is that a possibility? Possibly so. And then the point of care question. Should we consider integrating some point of care testing? And if we had that testing in Mr. Juarez's case, would it have made a difference? So we have quite a few questions here. I appreciate everybody's input. I think what we will do is do a further research on this, asking ourselves these questions, reconvene. Teresa, you're going to be leading the charge to put together kind of a quality plan together about what we should do, and taking everything that each of us had to say into consideration. Does anyone else have any final thoughts on this?
I just wanted to say, due to the seriousness of this, I'm going to be scheduling a meeting again in 2 weeks, just so we can stay on top of this and keep moving forward.
And you did say this has been reported to Joint Commission?
Yes, it's been voluntarily reported.
And we're doing a full root cause analysis with all parties involved. Is that correct?
Yes, and then eventually we'll be writing a quality improvement report.
Perfect. Perfect.
Okay.
Well, unless anyone has anything else, I want to thank each of you for being a part of this, and thank you for offering your expertise and your time. Thank you so much.
Thank you.